All right, let's get started. Always a pleasure to introduce Dr. Gilliland, who is speaking today. Dr. Gilliland earned his medical degree from the University of Kansas, then did his residency training here in our program at the University of Colorado, and then did a critical care fellowship at WashU in St. Louis. And in 2016, he finally joined our faculty, and since then, he's on the liver transplant team, works as an attending on the cardiothoracic ICU, and he's really highly involved and has a high interest in quality improvement. And as such, he's now also organizing this part of Grand Rounds. I'm very thankful for that. And he also is now the co-director of quality improvement and patient safety. All right, looking forward to the talk. Thanks a lot, Sam.
Good morning. All right. So today we're going to talk about a couple of cases. So the first case that we're going to discuss is an intraoperative guide wire retention. So we're going to focus primarily on this case, but I will bring in some elements from actually a second retained guide wire that happened about 6 months ago. So we've had two of these events in a relatively short amount of time. We'll discuss strategies for prevention and early identification based on root cause analyses of both of those two cases. We'll then talk about a case of a missed cardiac implantable electronic device interrogation and reprogramming postoperatively. We'll talk about indications for for preoperative interrogation and reprogramming, and then look at our current workflow here at UCH, as well as some ongoing process of improvement projects focused around this problem. So before we dive into these cases, and especially when talking about the retained guide wire, this is defined really as a never event. So a retained foreign object, whether it be surgical, whether it be from one of our procedures, is a never event in surgery. And despite calling it a never event, it happens quite a lot. And so when we talk about these, we really talk about four major categories of contributing factors. The first being unsafe actions, then preconditions for these actions, oversight and supervisory factors, and organizational influences. And so to dig into that a little bit more, so a lot of times when something bad happens, the immediate reaction is to focus on unsafe actions because these are things that you can pin on one or two people. These are, you made a mistake, you hurt somebody, and there's a blaming that goes on and sort of a shaming that can really drill down on providers. And when we talk a little bit more, there are all these other contributing factors that really, when you look at it, you say, wow, it's kind of amazing these things don't happen more often. But when we talk about unsafe actions, we talk about perceptual errors, so interpreting situations incorrectly, making the wrong decision, having some action-based errors, and then moving into compliance, bending the rules, breaking the rules. One of the things that we talk about a lot in patient safety and quality improvement is that nobody shows up to work to do a bad job. Nobody shows up to hurt somebody. And so, when we talk about these, we always have to discuss these actions. But really, that's sort of the realm of peer review. If these are things that show up frequently with certain providers. But that's not really the focus of a lot of what we do. So we tend to look at preconditions, so environmental factors, patient factors, situational issues, conditions of the care providers. So are there limitations in those providers' experience and their training? Physiologic factors, are they fatigued? Are these things happening in the middle of the night? Are there distractions? And then personal factors, so things like team resource management. Are the right people there at the right time? Oversight and supervisory factors are fairly self-explanatory, so we won't dig into that too much. And then organizational influence, resource management, so equipment issues, budgetary concerns, organizational climate, so is there a culture of patient safety, and are there some operational and process issues that we could potentially address? So to move into our first case review, so this was a 24-year-old male, history of methamphetamine abuse, who was brought in by ambulance. He was riding a bicycle, got hit by a semi-truck. He was hemodynamically unstable in the emergency department. They placed a Reboa percutaneously, balloon was inflated, MTP was initiated, and then this patient was taken directly to the operating room for an X-lap and to look at a grade 5 renal laceration and a grade 5 splenic laceration. Kind of the caveat to the hemodynamic instability, and as anybody who's done one of these big trauma cases knows, a lot of times when that Reboa goes up, things get a lot better, a lot faster, depending on where the bleeding is, depending on what kind of patient that you're dealing with. So when the patient reached the OR, he was actually hypertensive, was on quite a bit less support, transfusion had slowed down, and they were able to sort of assess the situation. Patient came up with 2 peripheral IVs. The attending anesthesiologist noticed that one of those IVs was infiltrated, and based on kind of where they thought this case was going, decided to place a central line. So this anesthesiologist placed a right AJ quad lumen personally. The 2 people that they were on call with, one was an early CA1, so this happened in August. And then one of our APPs who was actually on their first trauma call, so relatively inexperienced providers paired together along with this attending. This all happened around 5 a.m. Patient was resuscitated.
Welcome to Denver Health Conference.
Patient went to a CT scan actually prior to going to the surgical ICU, which is not infrequent in our trauma patients, and on that CT scan they actually noticed that the wire was still inside the central line. And so on arrival to the STICU and after appropriate access was obtained, that line and wire were removed together. In talking to the attending anesthesiologist, they were saying that while they were placing the line, they were also actively directing resuscitation of the patient, again, relatively hemodynamically stable, but with 2 relatively inexperienced providers, making sure that things were being transfused appropriately, that they, as we've all seen during line placement, it's not like the patient magically is all the way better. There are still things that need to be done to make sure that they're safe while that line's going in. Had turned around to direct, had actually initially seen the guide wire coming out of the line. When they came back, wasn't there anymore. They were moving pretty fast. They figured I probably already removed that, went ahead, secured the line, and got going. So just to keep in mind those silos that we were talking about, this is sort of the Ishikawa diagram that we broke down in the root cause analysis. So management decisions, again, these are sort of these unsafe actions that we were talking about. These are difficult to design for. These are things where if we recognize things, it goes back to training, goes back to education. One of the things that was identified was that the medical supervisor moved into the procedural role. This is actually something that we may not see in the operating quite as much, but we certainly see in the ICU, especially in code situations. You have a patient who's unstable, who needs a procedure. The most qualified person to do that procedure is also the one who's supervising medical care. And so when you move from that supervisory role into that procedural role, then it limits your ability to do really any of those things as well as you were doing them before. Obviously, wire removal is not confirmed. That was a problem. And then this last point, the not detected on initial chest x-ray, that was actually part of the previous retain wire event, was that the post-op x-ray on that patient, the ICU team recognized that there may have been a wire in place. Radiology did not read it as a retained foreign object, and actually that patient got several x-rays before they were able to confirm that there was, in fact, something wrong. So moving into these preconditions for action, so from an environmental standpoint, there was hemodynamic compromise, but in talking to the attending taking care of the case, it wasn't really anything particularly severe at that point, not anything outside of the realm of expected. Certainly there are distractions with trauma management. You're doing more than just kind of managing that hemodynamic compromise after induction and initiation of anesthesia, dealing with relative hypovolemia. And then this happened early in the morning, 5 o'clock. So anybody that's taken a trauma call before knows that you're nice, you're comfortable, and then somebody calls you and everything's all happening at the same time. It's a pretty chaotic environment, and there's not a lot of people around at that time of night. From a personnel standpoint, like we talked about a little bit already, this was an early CA1, very early in their training, one of their first calls, and then an APP who was actually on their first trauma call. So pairing those two together can make it challenging to do some of these more complicated cases. And then with those inexperienced providers, then sort of forcing the attending into the situation where they were placing that central line. Always have to worry a little bit about provider fatigue and some of the communication that goes on in the operating room when those things happen as well. And then from an equipment standpoint, there were a few things that we had discussed at the initial RCA. The first is that these quad lumens, for the sake of expediency, have the buff caps already in place. So one of those buff caps actually needs to be removed prior to placement of the line so that wire can come out of that port. There had been a recommendation, we'll talk about this a little bit later, to remove those previously. That unfortunately had not been done yet. And then we don't really have a visual cue or reminder in our kits to say, hey, this is part of the procedure. We have all these guidelines around CLABSI prevention. We use the little blue discs. We have the sterile drape. We have all these barriers that we go through, and there's a very regimented process to prevent CLABSIs, but we don't have anything to make sure that we complete the procedure safely and that we get everything we need out of the patient. There's no count like the surgeons have at the end of the case, especially in a trauma case like this. And then from a process standpoint, line placement is really the only thing that happens in the operating room that no one but the anesthesia team is involved with. So you think about just about everything else we do with the patient is either, induction, intubation, we have a nurse at the bed. Well, we're supposed to have a nurse at the head of the bed helping us. In case we run into airway issues, the surgeons always have the assistance of the nurses, the scrubs. Lines were pretty much on an island. So you're up, you're doing it by yourself. You have an attending who's maybe running between a couple of rooms. So there's not the same collaboration with the rest of the OR, and it really is 100% put in the anesthesia silo. And then there's no real process for guide wire removal other than, hey, don't leave the guide wire in there. So it's something we'll discuss a little bit moving on. So leverage points that come out of that, the first thing that comes up when we talk about management, again, is education. So making sure that the people who are involved are educated appropriately, are trained appropriately to get these things done, especially when they happen in a more urgent, emergent situation. So making that a part of APP orientation, making sure that we emphasize this with the CA1s as they start. Education interventions are hard. You almost always see an early uptick in compliance. You see a little improvement, but they're not very sustainable because, as we've all seen, we constantly have learners in the operating room. We constantly have turnover, and to sustain that is very difficult. And so then we have to start designing around systems. So staffing was one of the things that came up, and this is also a very challenging intervention. So you have an early CA1, and then you have an APP who was really just starting their career very early on. So how do we make sure that, especially in these summer months, that those people don't get staffed together? Well, it sounds like, well, yeah, just don't staff them together. That's easy until you talk to the people who actually do the scheduling and you realize the kind of endeavor it is to make sure to balance time off and vacation and experience and comfort level and actually seeing, we all get credentialed for things, but we certainly all also have differing levels of comfort with a lot of these procedures. So it's something that we're looking at, but is very much a problem. Documentation is one of the things that came up. We go through and we document everything that we do for the line, what size it is, where it is, how it's secured, but there's nothing, in that little checklist that said, a little cue that says, oh, we also remove the guide wire. Now, is that going to stop us from leaving it in the first place? Probably not, but it may lead to recognition in the operating room, or it may just drill in, hey, this is something I need to remember while I do the procedure, but maybe doesn't reduce the actual incidents. One of the things that we're actually talking about tomorrow in a meeting is we are pushing our nursing staff to become more involved in these procedures. Like I said before, this is one of the only things that happens in the operating room where it is 100% left to one team. So to make sure, whether we include the guide wire in the count, whether we verbally confirm insertion and removal with a member of the nursing staff, there has been some pushback. Their argument is that the techs should be involved in this. We have said that we don't have the manpower to do that for all the lines we do, especially in the middle of the night, especially when there are other things going on. You know, the nurses are the only ones that are consistently in the operating room when these things happen. So we're going to continue to push that. Including a visual cue in the kits. We'll talk about this in just a minute. And then finally, kind of a quick change to the chest X-ray order that actually doesn't exist in the PACU order set. So after this happened initially, we recommended that a visual cue be added to the kits. We made this recommendation about 6 months ago, and it's just a piece of paper that goes on top. It's not a magic bullet. It's just something to kind of cue people to say, hey, remember, this is part of the procedure. Please think about where the guide wire is. This, unfortunately, was tied up in value analysis. So whenever we make these recommendations, they then go to somebody who looks at how much it costs and comes back to us and says, hey, this is going to be the initial or the expense incurred. Do you guys feel like there's going to be enough clinical benefit? So initially they came back and said that this would be about $7.50 per kit for a piece of paper that goes in the kit sterilely. This would increase our total cost by about $34,000 a year. When we followed up with Teleflex, who actually owns Aero, who provides our kits, they said, yeah, we don't really know why that would cost any extra money. As far as we're concerned, that shouldn't really cost anything. So this is one of the fun bureaucratic things we get to deal with when we have a problem, is figuring out, is this real? So pushing back and making sure that, you know, this is something we can do and we're not incurring a big expense for something that, again, we think would help, but it's hard to say that this would definitively solve our problem. So speaking of value analysis, talking about cap removal. So this was something that came up in a previous retained guide wire event. Central line was placed, that buff cap was never removed, but everything was confirmed on ultrasound. Yeah, my wire's in the right place. Yes, I dilated, I put the line in, and then because the guide wire was never seen coming out, it was never then removed, and that was found, unfortunately, later in that patient's hospital course. These quad lumens and triple lumens are the only kits that actually have the caps in place, which is a little hard for a lot of our residents, considering that most of the lines that you'll place initially as a trainee are surprisingly things like a Cordis or an HD catheter. Our cardiac cases almost always have an introducer catheter. A lot of our liver transplant patients get HD catheters and introducer catheters as well. So while we do place a lot of quad lumens and triple lumens, it may actually not be the kit that we're most familiar with, and when you have changes like that, then you have problems. We are able to remove all the caps. We're not able to remove one selectively to provide that extra cue to say, hey, on this brown port, this is where you should see the wire coming out, but it's something we're continuing to discuss. So this was an interesting project that actually won the APSF Award for Innovation and is an example of designing to prevent error. I'm not recommending that we actually bring this into our operating rooms because we'll talk about there are a couple issues that go along with this. But what they do is they remove the line securement materials and they actually sequester it in this locked compartment. And to unlock the compartment, you actually have to use the guide wire. So you actually thread the guide wire through this little lid, and then once that's in, you can pop the top and you can remove your securement materials. So it makes it hard to do the wrong thing. You have to use the guide wire to get it out. So very cool, very interesting. Probably cost prohibitive to bring something like this into the operating room. We could consider removing our securement materials from the kit itself. The only problem with that is that, and we've discussed this with the resuscitation committee as well, is that because these lines are universal, this is the same kit in the operating room that it is in the ICU, that it is everywhere else in the hospital. So while we can say, oh yeah, we'll just remove it and we'll have the scrub nurse hand us sterile materials to secure the line, that's not going to exist everywhere. But it is an example of designing for these issues and making it difficult to actually incur an error without really trying. So the last thing that came up was this x-ray order. So there's not currently a chest x-ray order in the PACU order set. So if you place a line, you have to remember to put an order in. You'd think that would be easy, but then you think about how many times we hand off these cases, especially big cases that are going to be long. A lot of our patients who have central lines are going to go through a few providers, a few attendings. And so there may not be that memory to make sure that an x-ray is placed. There is a specific x-ray for central line placement that asks them specifically to look for retained foreign objects. In my mind, should be something that radiology always looks for, but then when you think about how many chest x-rays those guys look at a day, just to make sure that they have some kind of cue to look for a retained wire. We'll kind of open that up for discussion. Does anybody have any questions or additional thoughts? Dr. Selzer.
Guidewire retention a problem in the other areas where central lines are also placed frequently, and what kind of solutions for those areas come up with ICUs, ED, that kind of thing?
So it is a problem. The particular issue with tracking these is that these are relatively rare events, and they're 100% based on self-reporting. So even if you look at the literature for retained guide wires, they think it happens in every 2,000 to 4,000 procedures. There's concern that incidence is rising. We know that this is happening in other parts of the hospital. One of the things that happens in the ICU and in some of these other procedural areas is that the nurses are involved in procedural placement. So there is typically some kind of confirmation. However, I'm not aware of a lot of other process improvement projects that are going on in those areas to address that issue. One of the benefits or detriments that we have as a department is because we put in so many lines, we can see these trends. With these rare events, it's more when was the last time this happened instead of how many times you're having this a year. So I think we really are the kind of the driving department in this right now. Dr. Tran.
You said there's a new provider for the CA1, junior APP. Was there a second attending needed to be there to help out?
So we discussed that, and kind of at the time, and again with the ROBOA up, with transfusion requirements coming down and the amount of hemodynamic support being relatively stable, at least with the initiation of line placement, they didn't feel like calling the second attending at that point was necessarily. Certainly in hindsight, that could have been useful, but really something to think about for our folks on call kind of going forward. Dr. Morabito?
Do you think we put at the queue, like when you put the note in the chart, like something that pops up and says, hey, was your guide wire removed? Yes, no.
Well, and that was kind of part of our thought process with putting it into the line documentation, is actually having that point at the bottom. One of the other issues with documentation that we've discussed with other projects is that if it becomes rote, a lot of our best practice analyses that pop up, you're like, sweet red box, click. Like, are we actually reading this? Are we actually following what it says? And if you put it in the documentation, you've then said, yes, I did this, but you may not have. You may have just been clicking a box, and so you've increased your liability without actually improving your outcomes. So it's a little challenging from that standpoint. Dr. Jameson.
It seems to me that in order to do this, you can't see the wire anymore. So just the fact that you haven't paid enough attention and you can't see the wires is really the problem. Having 10 years ago was part of one of these events. I can tell you that is a big part of the problem, is something that keeps you from actually losing the wire, because you turn away, it will just floating down so you can't see it, and getting it out is now becoming a deal. So how do you keep it from vanishing?
Yeah, and I think that's part of technique, that's part of education, that's part of training, is making sure that you keep a hand on that when you're moving things around. Like we noted before, there are all these other extrinsic factors. You're in a trauma, you're trying to direct, there are all these distractors. It's 5 o'clock in the morning. But certainly part of that is making sure that when you're doing these lines in a non-emergent situation, that you're practicing good technique. So when you get to the point where you can't think about it as much, your technique is still sound.
One last question. So if I do this in your ICU, is there always someone?
There's always a nurse in the room. So they have a procedure navigator that they're supposed to follow. They don't always, but part of it is because we then have to sometimes direct sedation or need people to run out for things because we don't have everything quite as available in these rooms. We do have somebody with us. There's also extra vigilance, especially in our mechanical support patients, because the risk of entraining air and wires is a little bit greater. We've had problems with that as well.
It seems to me that the bottom line is when does the incidence of this and the complications associated with this reach the point where the requirement is to have an assistant?
And that's what we'll push in our meeting tomorrow, is that because these are rare events and because we're looking at time between events, these are things that we can track but are more difficult, but our push will be, this is happening more frequently, and in the literature it actually looks like nationwide this is happening more frequently, and that will be part of the conversation. Dr. Tran.
Sorry, go back to this. What they said, I don't think it has to be an assistant, but I think how we do central lines may have to change. Yes, I do a lot of ultrasound. I always look for pneumothorax after I place it. Is it one of those things where it's kind of part of your practice plan? Yes, you scan the neck, make sure the wire goes caught at, or stuff like doing a growing line, and then you also look for pneumothorax. It's kind of also a practice pattern for us, too, to elevate our standard of care.
I think that's a reasonable thing to discuss. I think the problem with that is when you get in these situations where things are moving quickly, unless you have that repetitive way that you do things every time, like you do, it may be something that you forget, and you are, again, you're relying on the provider to have that training, to have that pattern recognition, to have that kind of muscle memory to do these things. And while it's reasonable to push that as part of the training, we also train people to remove the guide wire every time, but it's still happening. Dr. Eckel.
I think it goes into what everybody said, but I'm wondering if that warning being removed the guide wire is good enough. So the way I was trained is that you never take the hands off the wire.
Mm-hmm.
Never. So wondering if that would be a better warning label, like the hands holding the wire saying to never let the wire go.
Yeah. No, I think that's very reasonable. We can talk about that with the Q. All right, Dr. Wilkie, it's going to be the last question. We're going to move on to the next case.
So my recollection is with the last case we had that was a 9-French woman, the distal lumen had a white sheath inside of it. The cap was a different color than the material, it was red. And there was actually a little sticker on there that said, leave this in place until you have a lining and then take it out. So I think that company was not a very good way of helping. And the cap didn't come on.
Yeah. We can certainly follow up. I will say that with those particular lines, we had that sheath left in place multiple times as well. So it's a little tricky to kind of trade one complication for another. But I agree, to have the Q on the line itself is fantastic. We did talk to Arrow to see if they could just remove the cap that the wire was coming out, and they are not able to do that. It's either they're all on or they're all off. No. I would actually love that. I fully support that because we've all had to trade those. We've had issues, especially with dialysis catheters in the MAX. If the lines are shorter and you have to swap it out, it'd be nice to have something longer. But certainly we could follow that up as well. Or fluorescent. Or it could make a noise while it's in there until you take it out. That would be awesome. All right. So our next case, and the caveat to this case is that no harm came to this patient. And it was really based on a miscommunication. However, this triggered an RCA because we've seen a lot of events like this over the last couple of years. So this is an 80-year-old with a history of severe aortic stenosis, heart failure with reduced ejection fraction, AFib, A flutter, status post-IV, PACER, and AICD in 2008, stage 3 kidney disease, type 2 diabetes, hypertension. So your standard cardiac patient. Coming in for surgical AVR was not a TAVR candidate, unfortunately, for him. EP was consulted for interrogation and reprogramming of the device prior to surgery, his tachytherapies were turned off, and there were instructions in the documentation to page the device clinic at the end of the case to resume tachytherapies. Excuse me. EP was not contacted following the case. That patient went to the CTICU and they had decided to hold off on resumption of tachytherapies overnight, given a possibility of return to the OR. The patient had a cold left leg. Pads were left in place if cardioversion was needed. This is not uncommon in the CTICU. Unfortunately, there is a percentage of our patients that do go back to the OR emergently in the first few hours. So to bring a patient back emergently and have those tachytherapies back on can actually be dangerous to the providers and the patients. So we do leave pads in place from time to time. The RCA was filed by a tech because they have had issues with not being contacted postoperatively for these patients, and actually patients showing up in device clinic who still had their tachytherapies turned off weeks later. So something that really raised a lot of red flags. Just as a quick review for interrogation of implantable defibrillators, pacemakers, and arrhythmia monitors, these are the 2011 collaborative recommendations with the American Heart Association and the Society of Thoracic Surgeons. This is really our document that gives us our primary recommendations on who do we interrogate, who do we need to change tachytherapies on, how do we manage these in the OR. So whenever you have EP push back on coming down and taking a look at the device, you can say, well, based on these guidelines, this is why I need you to come down. And sometimes the last guideline is the most important, which is it all comes down to individual management. So if I'm asking you to come do this, please come do this. So really the big take home from these and the things that need to be communicated from the EP team to the perioperative providers. Data last interrogation, so these need to be done within 6 months for an ICD, that's supposed to be a CRT device, or 12 months for a pacemaker. What type of device is it, the manufacturer, the model. The big things that are important for us is why do they have a device? So if it fails, what are they going to look like? So do they have sick sinus syndrome? Do they have complete heart block? If this fails, am I going to be in a lot of trouble? Or do they have a perfusing rhythm underneath? So going back to, are they pacemaker dependent? How are they currently programmed? How does the device respond to a magnet? A lot of times you'll have, specifically some of our surgeons will say, no, we don't need to do that. Just put a magnet on, it'll be fine. It's not a big deal. Well, not everybody responds to a magnet the same way. So it's very important to know what happens when you do that. Is there any alert status, or are there any recalls or any issues? This patient actually did have a recall on his device, but it didn't end up being important. And then individual recommendations or prescription based on patient information, device characteristics, and surgical factors. So is there a risk of electromagnetic interference? Where's the surgery? Is this going to be a problem with where their electrocautery pad is? What's the patient's response to asynchronous pacing? These are all the things that we need to talk about before we take these patients to the operating room. So our current workflow with device interrogation reprogramming is we review the chart, we see if they meet criteria, we place an order in Epic. This is part of our preoperative order set to, hey, please come interrogate this device. The nurse contacts EP, the device is interrogated. There's a purple sheet that they fill out in addition to their documentation in Epic. The reason why that makes a difference is they fill out the purple sheet at the bedside. They generally don't put their note in until they get back to clinic. So there's a pretty big delay between when those things go in, but if you need something right away, that's where that sheet lives. We take the patient to the OR, we place another order in Epic to make sure that they get interrogated. Afterwards, either the nursing staff or the primary team contacts EP depending on where they go, and then we interrogate the device, plus minus reprogramming. So in looking where things broke down, so management, the big things, nobody contacted EP afterwards. Somehow it made it to the nurse the next morning that this device needed to be interrogated. And then there was no follow-up on the other side of EP. So they reprogrammed this device, but there was no mechanism for them to come back and follow up on the patient. It just happened that EP nurse remembered to talk to the EP fellow and said, hey, would you mind just checking on this guy in the morning? Case finished late. From an environmental standpoint, these EP nurses have multiple interrogations and reprogramming consults each day. And then there are variable patient dispositions. Some of these patients go to the ICU, some of them go to PACU and they're admitted, some of them go to PACU and they go home. So keeping track of these patients and making sure that they're seen again in a timely manner is challenging. From a personnel standpoint, the responsibility for interrogating these devices differs depending on what time you call. If you call during the day, it's going to be the EP nurse that come over from clinic. If you call early in the morning or at night, it's going to be the EP fellows. This is, from their standpoint, a fairly onerous consult, and tends to happen in the middle of their conference in the morning or when they're trying to sign out, when they're trying to get out of the hospital, so that can be challenging. Communication responsibility differs depending on whether you go to the ICU or whether you go to the PACU. And then multiple providers, attendings, nurses are involved in these cases as well. So, obviously there's a nice visual cue on the chest. I'm sorry about that. That little pacer pocket should let you know that they have a pacer or an AICD. But a lot of times you can get through a case, you've gotten handoff from one or two other people, and suddenly you're seeing, oh, this person has a device, and maybe that got lost in handoff. From an equipment standpoint, there's no dedicated documentation point for these devices. So what we see, that little lightning bolt on the heart on our OR staffing, we're the only ones that can see that, and that's placed either by pre-procedure services or by the nurse that calls these patients prior to coming in the next day. It's not uniformly documented, so there are cases where we'll show up and find out that they have a device, even if it didn't show up in our little worksheet. Because there are multiple ways to document that a patient has a device, but there's no one standard way, it's very difficult for EP to generate a work list of the people that need to be seen in the morning or that are potential interrogations, because pulling that actually becomes very difficult in Epic, despite all the promises when we moved to Epic that it was going to make our lives easier. And then again, there's no visual cue outside, of course, this nice big pocket on their chest. That purple sheet that we fill out isn't always readily apparent. Like a lot of things, it gets shuffled into the chart, and so unless you're looking for it, unless you're doing a pretty thorough look through of that chart, you may not see that device has been interrogated. And then going back to that process, there's no work list for AM interrogations, there's no work list for follow-up, and there's no formalized handoff between the EP nurses and the cardiology fellows. And then the last thing is that we have two separate orders for interrogation. So in our pre-op order set, we have an interrogation reprogramming order. In our PACU order set, we have the same thing, but those things, as of right now, are not linked. Which brings us to some of our leverage points, making sure that there actually is a formalized handoff between the EP nurses and cardiology fellows, and to tie into that, make sure that we can develop some kind of work list, some kind of prompt. If you carry your phone around, you can get a little prompt that says patients in pre-op, patients in the room. Having something like that would be easy for the nurses to use to give some kind of indication, hey, this patient's reached PACU, this patient's reached the ICU, maybe it's time to go and take a look at their device. Standardizing who calls, so in the ICU, it's usually a resident. In the OR, it's typically going to be our nurses in PACU. Linking those pre- and post-operative interrogation orders, adding a visual cue that actually lives with the patient outside of just this thing on their chest that's going to be covered by a gown, which I'll show you here in a minute. Creating a standardized location for device documentation to develop these morning work lists to see are we staffed appropriately so we can run into fewer issues when we're calling in the morning and people are running around. And then, like what we talked about before, creating that shared work list. So this is that purple sheet that we're talking about. Hopefully all of you have seen this. If you haven't, and you have a patient with a device that needs to be interrogated, make sure that the EP nurse is filling this out. So that you should be on the chart, not only to say that it's been done, but to say what they've done and what needs to be done going forward. We've added this cue to the patient themselves. These are these cardiac device armbands. When a device is interrogated, the pre-op nurse will place this armband on the patient, and then when it is reprogrammed and reinterrogated, it's like PowerPoint's done. We're finished. This will be removed and documented. All right, everybody always has a nice picture of their family when they do this. This is the best picture we were able to get from Halloween this year, was the baby crying, the toddler terrified, My wife was with the program, but yeah. Anyway, does anybody have any questions, suggestions? Dr. Nelson.
So, Sam, do you happen to know at the other locations that UC Health, such as Broomfield or over at Highlands Ranch, is the same CIUD standardized process being worked there or developed?
So we're starting it here, and we're going to see how things go. We have reached out to South to see if they have a process that they're working with, or they've seen these other issues. Unfortunately, we haven't heard back. But the hope is to roll it out, and if we're successful, to then bring that to our other systems. One of the issues that we've run into, especially with order sets and some of these things that we've been working on, is that we now have to get sign-off from North and South on the change of most order sets, which can be challenging. Dr. Kakmar.
Thanks, Sam, for the presentation. I think having EP buy-in is going to be the actual key to this process. I actually took care of a patient in that issue a few weeks ago where they'd done a really nice consult in the chart and addressed 0 of the items that you mentioned were important to know. And it was a pacemaker-dependent guy who had a backup of 100. So I think one is getting their actual buy-in, potentially having something like a checkbox in the scheduling of cases to put some of it on the surgeon too to notify people when they know they have it, help generate that work list in the morning ahead of time or the night before. And then I think it's going to be somewhat of an issue at some of these other places because we don't have in-house ability for consultation or monitoring. So having that information ahead of time is going to be important.
And EP has been at the table for these discussions. They were present at the RCA, both Wendy Zhao and then the nurse manager. They were the ones that actually brought this issue to our attention. I do think it's reasonable to go back and look at their template and make sure that, like, hey, when you're doing these perioperatively, like, these are the things I really want to know. Like, yes, it's great to know what their thresholds are and how old their battery is, but what happens if it stops working? How do they respond? You know, I did the same thing. I had a GI patient that, you know, on page 7 of the consult, it said, responds to magnet appropriately. So making sure that we actually have the right documentation for what we need in the operating room, I agree, is very important. Dr. Jameson.
One last thing to remember is that they may have a vagal nerve stimulator in that spot.
Mm-hmm.
They have EDSs in that spot, and usually there's no pieces all over it. But just seeing the little device you did may not be the answer to the question. It should do great harm with those.
Dr. Kakmar.
One more thing with the armband. I think if we're worried about information lost in handoff, I think the armband is not quite as helpful as something on or down over the device. Because if their arms are tucked or under the grade, we're not going to see that.
Yeah, I think the main push behind the armband is to make sure that the people that are going to be communicating with EP, either the resident or the nurse in PACU or the ICU, actually sees it. But I do agree, having more of a cue on the patient would be helpful. Dr. Selzer.
I just wanted to add to the conversation what we do in PPS and for patients that have implanted cardiac devices. I don't think this patient came through our clinic.
They did not.
A lot of patients with these devices do not come through our clinic, but patients who come through the clinic or who are booked at least 4 days in advance will get a call from one of our nurses. And everyone, we've instituted a process that even if they're not coming to clinic, they're getting a phone call with instructions where to come, when to stop eating, whether or not they can have bone broth. We have the nurses look to see what type of device do they have. If it's a defibrillator, we request and confirm that there is an interrogation report in the chart. So that would be under media tab if it wasn't interrogated in our hospital. And then if it wasn't done, or if the report says battery life low, needs another interrogation, then we trigger in-basket message to EP and the EP device group that patient will need to be interrogated on the morning of surgery and what type of device they have. So we have that process in place. We don't comment when they come into clinic on how the device should be managed. Mm-hmm. That's something we could do if that's something that people in the department are interested in. But we really leave that up to the individual provider. We just make sure that all the information that is needed is in there. And sometimes the interrogation report doesn't tell you everything you need. You need to call the device manufacturer to find out exactly what happens with the magnet. A the last thing I wanted to comment on is a lot of the newer models have electrocautery canceling features. So if it sees electrocautery or senses electrocautery, it will not pace or fire. So unless a patient is pacer dependent, meaning that more than 40% of their beats are paced by their device, or requires frequent defibrillation, you usually don't need to reprogram those devices, even if surgery is going to be above the umbilicus.
Yeah, and that's an excellent point. And that was something that came up in some literature review as well. I mean, this guy was placed in 2008, so probably didn't have some of those therapies. And so we still need to look at the device to make sure, you know, if it was put in the last year, it may very well have those things. But
and cardiac surgery, I think, is not in that bucket of above the umbilicus surgeries where you wouldn't reprogram it.
yeah. All right. Anything else? Thanks, guys.